Good morning. This is the presentation for NUR 510, Advanced Pathophysiology, Musculoskeletal System. It's going to be divided in two parts, part 1 and part 2. You are responsible to review these two videos in order to increase your knowledge on musculoskeletal pathophysiology and all the illness related to it, in addition to be competent for next week quiz and for the exam as well. Well, the skeletal system is basically composed of bone and muscles. Bone is a connective tissue, and before I proceed to the types of bone, let me explain a little bit how the bone is formed, which is basically osteogenesis. Osteogenesis arises from mesenchymal stem cells that are found in large number of the periosteum. These are fiber-like layers on the outside of the surface of the bone in the bone marrow. During cellular differentiation, you would see that there are two types of bone cells, which are the osteoblast and the osteoclast. Osteoblasts, they develop from the progenitor cells and basically are active in the chondrocytes. They also are in charge of transcription of the osteoblastic differentiation. It's necessary for bone formation, certain regulatory systems, and in addition to cofactors such as calcium, phosphate, carbonate, and magnesium. Many of the regulatory systems are involved in the transition of cartilage to bone and in the maintenance of the bone, reflecting that the skeleton is a large organ that is formed and degraded throughout life. These are regulated by parathyroid hormone, which is a protein made at the level of the parathyroid gland under the control of serum calcium activity. PTH, which is the parathyroid hormone, also has important systemic functions, including to keep the serum calcium constant regardless of calcium intake. A common misconception is that the more calcium you incorporate in your diet, the more calcium you will have in your bones. But this is not reality. It's not a significant mechanism supporting osteoblast bone formation. Patients with very low dietary calcium, the body is smart enough to be able to regulate and increase calcium formation or resorption in order to maintain calcium at the level of the bone. So before I continue, let me explain what is an osteoblast and what is an osteoclast. Osteoblasts are the major cellular component of the bone. Again, they are the functional part of the bone matrix. Consists of protein and minerals. They basically form the bone. Versus osteoclasts, which break down the bone. Basically, they're in charge of resorption of bone. So again, they allowed bone remodeling. Osteoclasts allow bone remodeling. They allow bone resorption. They are basically formed from the monocytes. They secrete citric and lactic acid, and they're stimulated by PTH and inhibited by calcitonin. Once activated, the osteoclasts move to areas of microfracture in the bone by chemotaxis. They are basically in charge of digestion of bone that is in the healing process. They also participate in prevention of osteoporosis because they interrelate with the enzymes such as lysosomes and cadapsin to maintain the matrix of the bone. Cadapsin is basically a protease that is mainly expressed in the osteoclast and is secreted into the resorptive area of the bone. Osteoclasts are regulated by several hormones, including parathyroid hormone from the parathyroid gland, calcitonin from the thyroid gland, and the growth factor interleukin-6. This interleukin-6 is one of the factors in the disease of osteoporosis, which an imbalance between bone resorption and bone formation is the main pathophysiology of osteoporosis. Osteoclast activity is also mediated by the interaction of two molecules produced by osteoblasts, which are the osteoprotegerin and rank ligand. An osteoclast can also be an instrument used to fracture and reset bones. So again, you need to know that the main function of the osteoclast is bone resorption versus osteoblasts, which are responsible for formation of new bone. These are the major cellular components of the bone. Remember, they basically belong inside the bone matrix. They allow the bones to be made, remodeled, and repaired. The osteoblasts come from the differentiation of osteogenic cells, and they basically finish working to harden the bone during the mineralization period. Osteocytes, this is the main cell from the bone marrow that is the final differentiation stage of the osteoblast. The osteocytes are basically osteoblasts which have become trapped inside the bone matrix. Once the osteoblast creates the new bone around itself, it is trapped and can no longer move or form new bone. When an osteoblast is transformed into an osteocyte, the transformation causes the osteocyte to lose the majority of its organelles. This is a picture of the osteoblast, which is the progenitor cell, forming new bone, transforming itself into a more mature cell, which is the osteocyte, that maintains the bone tissue. And the osteoclast, remember, is in charge of cleaning up the area, resorbed bone, and basically repairing. Now, types of bones. The classification of bone types could be from long bones, short bones, flat bones, sesamoid bones, irregular bones. For example, long bones are characterized by having a shaft, which is called diaphysis, that is much longer than is wide. They're made up mostly of compact bone with lesser amount of marrow. They're located within the medullary cavity, and they also have spongy bones. Examples of long bones, you have the femur, the humerus. Short bones are roughly cube-shaped. The bones of the wrist, the ankles, are short bones, but at the same time they're sesamoid bones. Those sesamoid bones, they're embedded in tendons. They act to hold the tendon further away from the joint. The angle of the tendon is increased, and thus the level of the muscle as well is increased. Examples of sesamoid bones besides short bones are patella. You also have the flat bones, which are generally thin and curved. Most of the bones of the skull and the sternum are flat bones. And lastly, irregular bones, which they consist in a thin layer of compact bone surrounding a spongy interior. Those are the spine, the pelvis, the sphenoid. In addition to this classification, we have other classifications, which are the compact bone, which basically is the majority of the bone type, which is 85%. Compact or cortical bone, they have an outer layer which is hard, is composed of compact tissue, so-called due to its minimal gaps and spaces. Is also very high in porosity. This tissue gives bone their smooth, white, and solid appearance and accounts, as I said, for more than 85% of the total bone mass of the adult skeleton. Compact bone, besides being called cortical bone, is also called dense bone. The compact bone has an osteon, which is their Haversian system, a central canal, lamella, lacuna, and canaliculi. Then we have the spongy bones, which are also called trabecular or cancellous bone. These are highly vascular and frequently contains the red bone marrow where hematopoiesis takes place. The filling interior of the bone is the trabecular tissue. It has an open porous network, also called cancellous or spongy, which is composed of a network of rod and clay-like elements that make the overall organ lighter and allow room for blood vessels and marrow. Trabecular bones account for approximately 15 to 20% of total bone mass, but has nearly 10 times the surface area of compact bone. It's high in porosity. For any reason, there's an alteration of the strain of the cancellous bone, the rearrangement of the trabecle has to take place. Typically, it's found at the end of long bones, where these bones articulate. For example, with the vertebra, with pelvis, etc. This is just a picture of where the osteon is located, the central canal. You have the periosteum, which is the outer layer of the bone. Examples of the compact bone, differentiated it with a spongious bone. Look at the network of porous trabecles that the spongy has compared to the compact bone. You have the matrix and the canaliculi, which is present in the compact cortical bone, that is not present at the level of the trabecular or spongy bones. Remember, the trabecular spongy bones are basically porous. Again, this is the compact bone and the trabecular or spongy or cancellous bone. Okay, you have the canaliculus inside. You have the Haversian canals in the compact or cortical bone that is now present in the trabecular or spongy bone. Again, you have compact outside and cancellous or trabecular or spongy bone inside. This is no more just to tell you how many bones are in the human body, and just an anatomic representation of all the bones in the skeleton. What is periosteum? Periosteum is no more than the outer layer that is dense, that is rich in nerves and blood vessels. Inside the periosteum, you have the osteoblasts that, remember, are in charge of bone formation. They're also anchored by collagen fibers that penetrate inside the bone. Before going to bone classification, let's talk a little bit about bone mineral homeostasis. The main minerals in bone are calcium salts and phosphates, besides magnesium, of course. More than 90% of calcium in the body is in the skeleton. Mostly are crystalline, hydro, apatite, which are deposited at the level of the osteoid, converting the bone into a hard bone matrix. You have what's called bone remodeling, which is the process of formation of or repairing a new bone. Remodeling, or what was also called bone turnover, is the process of resorption followed by replacement of bone with little change in shape, and occurs throughout a person's life, or when you have a fracture. Osteoblast and osteoclast coupled together via paracrine cell signaling, which is the parathyroid hormone and the calcitonin, are referred to as bone remodeling unit. The purpose of remodeling is to regulate calcium homeostasis, and of course repair every time the bone suffers stress. To be able to have remodeling, the bone has to be in balance with the calcium. The process of bone resorption by osteoclast releases stored calcium into the systemic circulation, and it's an important process in regulating calcium balance, as bone formation actively fixes circulating calcium in its mineral form, removing it from the bloodstream. Resorption actively unfixes it, thereby increasing circulating calcium level. Repeated stress, such as weight-bearing exercises or bone healing, results into bone thickening, and of course they're going to be developing points in the bone, which are called points of maximum stress by formation of calluses. What is paracrine cell signaling is what I just explained, that the action of osteoblasts and osteoclasts are controlled by chemical factors that either promote or inhibit the activity of bone remodeling cell. And these are controlled by the paracrine stimulation of PTH. Osteoblasts can be stimulated to increase bone mass through increased secretion of osteoid by inhibiting the ability of osteoclast to break down osseous tissue. So when the osteoblasts are activated, the osteoclast has to be inhibited. Bone building through increased secretion of osteoid is stimulated by the secretion of growth hormone by the pituitary. Thyroid hormone and also sex hormones, which are estrogen or androgens. These hormones also promote increased secretion of osteoprotegerin, which is a precursor of formation of osteoblasts. Osteoblasts can also be induced to secrete a number of cytokines that promotes reabsorption of bone by stimulating osteoclast activity and differentiating it from progenitor cells. Vitamin D must be present, and that is secreted by parathyroid hormone, and stimulation of osteocytes induce osteoblasts to increase secretion of rank ligand and interleukin 6, which cytokines then stimulate increased reabsorption of bones by osteoclasts. So in other words, there has to be a balance between formation and a balance between inhibition or resorption. Otherwise, osteoporosis takes place. The rate at which osteoclasts resorb bone is inhibited by calcitonin. So PTH induces osteoblast formation, and calcitonin stimulates osteoclast. Calcitonin is produced by the parafollicular cells in the thyroid and can bind the receptors on osteoclasts to directly inhibit osteoclast activity. So now let's talk about bone classification. You have diaphysis, metaphysis, epiphysis, and as I already explained, examples of flat bones, which are ribs and scapules, and irregular bones, which are vertebrae and facial bones. So what is diaphysis? It's basically the midsection of the bone. Metaphysis is where the joining takes place. See that this is, for example, a femur. You're going to have this being joined by the pelvis. And epiphysis is the actual end bulbous of the bone. The long bones have diaphysis, metaphysis, and epiphysis. They also have a medullary cavity and an endosteum. What is an epiphyseal plate? Basically, a child, as anybody else, has an epiphysis, but that epiphysis has not grown completely or has not finished the growth capacity until after puberty. So anytime there is an illness related to the muscular or bone tissue formation before puberty, the patients or the pediatric population can have short stature. Any surgeries related to the bone has to be thought to be performed after puberty due to the lung capacity, the capacity of the bone to continue growing. This is very important, and you need to know that the degrees of movement on the joints. There's synarthrosis, amphiarthrosis, and diarthrosis. What is synarthrosis? Synarthrosis is an immovable joint. There is no movement capacity whatsoever. For example, the suture of the skull are synarthrosis. And you might be thinking about, well, there is movement in the infancy before 1 year old or the neonate, and there is movement, but we're talking about once it's already sealed, the actual skull is immovable. Amphiarthrosis, they have slightly movable joints. Examples of amphiarthrosis are the vertebra. And diarthrosis are freely movable joints, and examples are the shoulders. And of course, there are many more examples that you have in your book. There's a question about Mike is an active baseball and football player in high school. Now at age 36, he's still a professional athlete. He has dislocated his shoulder many times, but even after several hip injuries, he has never dislocated his hip. Why is the shoulder more likely to have a history of dislocations? And the answer is because of the pectoral girdle is designed more for mobility than strength. When you apply a force to that fossa, the neck of the femur is longer and more angled than the neck of the humerus. So the pelvic girdle is attached to the vertebral column and thus more stable than the pectoral girdle. Type of synovial joints. You have the fibros, the tendons and ligaments in the capsule, along with the nerves, blood, and lymph vessels. The capsule is a connective tissue that covers the ends of the bone where they meet in the joint. It's made up of parallel bundles of fibrous tissue. Then you have the synovial membrane, which is very smooth and delicate inner lining of joint capsule. And inside you have also loose fibrous connective tissue and blood vessels that are necessary for repair. In the synovial membrane, you also have type A and type B synovial cells that are in charge of ingesting and removing bacteria. And also inside, type B synovial cells are necessary to secrete hyaluronate. That protein is in charge of providing the viscous quality of the synovial fluid. And you have the joint synovial cavity, which basically is an enclosed fluid-filled space in the joint surface of two bones. And inside you have the synovial fluid, which is synovial fluid is no more than a filtrate of your plasma. It lubricates the joints, it nourishes the bone pad, and also has synovial cells, leukocytes, and macrophages that are in charge of phagocytosis of debris and microorganisms. These are examples of the joint capsule and the synovial fluid inside that separates two bones and basically is in charge of nourishment and avoiding trauma of joint. The articular cartilage reduces friction and also distributes the force. We already explained what synovial fluid was about. Now let's talk about fractures. Fracture is no more than a break in the continuity of a bone and occurs when a force is applied that exceeds the tensile strength of a bone. To be able to talk about the classification of fractures, you could classify fractures as complete and incomplete, open or closed. For example, complete fracture, the bone is broken all the way through. And incomplete fractures, the bone is damaged but still in one piece. Open fracture, they're formally referred as to compound fracture, is when the skin is basically open and you could see the bone outside. Closed fracture is also called simple fracture, a fracture in which a bone breaks into more than two fragments. Is also called comminute fracture. You also have the linear, the oblique, and the spiral fracture. Linear runs parallel to the long axis of the bone. The oblique is a slanted fracture of the shaft of the bone, and spiral fracture encircles the bone. There's also transverse fracture that occurs straight across the bone. Green stick is very common in pediatric population because of the nature of flexibility of the cortex. Basically, the cortex is perforated, but there is no substantial or disruption of the cortical bone. So basically, the perforates one cortex and there's a splinting in the spongy bone tissue. The outer surface is disrupted, but the inner surface remains intact. Also, there is torus fracture, where the cortex buckles but does not break. Bone fracture occurs when longitudinal forces is applied to the bone. This type of fracture is also present in pediatric population and is very common in the radius, in the ulna, in the fibula, in the tibia. When you twist a child's arm, you could provoke a green stick or a bone type of fracture. Then classification continues, and pathological fracture is a break at the site of a pre-existing abnormality, usually by force that would not fracture a normal bone. Stress fracture occurs in a normal or abnormal bone that is subject to repeated stress. For example, a military person who's trying to march, stepping on his foot constantly could produce a stress fracture. These are picture representation of the types of fracture. You have oblique, open. You see the skin actually is also affected, is perforated, and the bone is sticking out. You have segmented, you have spiral fracture, transverse, green stick, and impacted. This is an example of a green stick fracture, again in pediatric population. Occurs when a bone bends and cracks, but there's no complete separation of the cortical matrix. Pathological fracture again occurs when a bone breaks in an area that is weakened by another disease process. Patients that have cancer, patients that have osteomyelitis, any type of bone infection or chemotherapy, radiation therapy, osteomalacia, osteoporosis. This is no more than radiographic representation of a comminute fracture. So the broken bones can damage the surrounding tissue, the skin, the periosteum, the blood vessels. They can actually form a hematoma. They can destroy collagen and fibers and tendons, and they basically trigger an inflammatory response. Now let's talk about stages of healing. In the stages of healing, when a bone is broken, the periosteum and the blood vessels in the cortex and the marrow surrounding the soft tissue are disrupted. So bleeding occurs, and therefore there is a formation of a clot, which is the hematoma, within the medullary canal. The bone tissue immediately adjacent to the fracture dies and forms a necrotic tissue. This necrotic tissue is basically composed by fracture and debris, That stimulates the inflammatory response that that is characterized by vasodilation, capillary permeability, and chemotaxis of leukocytes, producing infiltration of more cytokines. The mast cell will degranulate. Within 48 hours of the injury, the vascular tissue invades the fracture area from surrounding soft tissue and marrow, and the blood flow of the entire bone is increased. That's basically invasion of the site by inflammatory cells and osteoclast activation by calcitonin that remove that then dead bone tissue. The fracture site changes from a clot to an organized fibrin network with invasion of vascular tissue that increases blood supply to the area, as already mentioned. Then the periosteum, the endosteum, and the bone marrow is activated to start forming new bone by activation of osteoblasts. So the bone-forming cells in the periosteum and in the osteum and the marrow are activated to produce superosteoprocallus. So those osteoblasts, remember that they are activated by the matrix and by PTH, and the osteoblasts within the procallus synthesize collagen and matrix. As the repair process continues, remodeling occurs, during which unnecessary callus is reabsorbed and trabecula are formed among lines of the stress fracture. Again, this is a representation of any type of stress to the bone, fracture, formation of the hematoma, traveling of all the pro-inflammatory mediators, formation of the soft callus, ossification by the appearance of osteoblasts in the periosteum, endosteum, and the marrow, and the process of remodeling. Again, there is an inflammatory response soon after the fracture occurs and the hematoma is formed. Macrophages and all the leukocytes and cytokines from the inflammatory cascade move to the area of injury. Their activation of Scandinavian debris and phagocytosis begins producing pro-inflammatory agents and to initiate healing. Formation of soft callus, which inflammation triggers cell division and growth of new blood vessels among collagen, proteoglycans, and fibrous tissue to form the soft callus. There's the hard callus, where endochondral ossification takes place. This is also present in the woven bone that replaces soft callus for the hard callus. And remodeling, where the actual bone is completely replaced by cortical bone or disorganized woven bone, because it continues to remodel and forms the healed tissue without scar. Manifestations, patients could heal properly, or they could have unalignments. So unnatural unalignments could occur: swelling, muscle spasm, tenderness, pain, impaired sensation, and possible muscle spasms as well. The treatment for fractures, is close manipulation, traction, and or surgery for open reduction. Now we're going to be discussing about the improper reductions or immobilization that you need to know for your exam. What is a type of malalignments are nonunion. Nonunion is a failure of the bone end to grow together. There's a gap between the broken end of the bone field with a dense fibrous or fibrocartilaginous tissue. Occasionally, the fibrous tissue contains a fluid-filled space that resembles a joint, but this is basically false and that's called pseudoarthrosis. Delay union is where there is reduction, but the actual reduction does not occur until about 8 to 9 months after the fracture. And malunion is healing of a bone in a non-anatomic position. The remodeling process substitutes the trabecular bone with compact bone. The trabecular bone is first resorbed by osteoclasts, creating a shallow resorption pit, remember. Then the osteoclasts deposit compact bone within the resorption pit. If this does not occur properly, you could get non-union, delay union, or malunion. This is an example of a malunion, non-union. This is a malunion as well because it's angulated. The treatment for fractures for delay or non-union includes different modalities. You could implant an electrical current device to stimulate bone growth in the non-union. Gene therapy, enlarged defect in bones that can be filled with also graft or synthetic material. Now let's talk about disease process. Let's talk about tendinitis. What is that? Tendinitis is an inflammation of the tendon. It's basically a tendinopathy. You could have Achilles tendinitis, patellar tendinitis. Is basically due to an inflammatory response. The type of tendinitis also are common in the upper extremities or rotator cuff tendinitis. Is basically frequent in patients that swimmers, in tennis, sports. Achilles tendinitis is also a common injury, particularly in sports, when the person has to be jumping constantly. Patellar, present in basketball players or volleyball players. Diagnosis of tendinitis. The symptoms basically are myalgias, pain located at the level of the joint, to a burning sensation that surrounds the joint, and there is inflammatory tissue also at the same level. When the swelling occurs, heat or redness could also be present. Patient complain of pain usually worse during or after the activity. If it's swimming or playing basketball or volleyball, etc. The tendon and the joint area can become stiff. So muscle could also tighten. Treatment for tendinitis basically is the use of non-steroidal anti-inflammatory NSAIDs, which are, your ibuprofen, Advil, etc. Physical therapy, occupational therapy, putting braces and orthotic devices. In worst cases, steroid injections can also be used. Now, bursitis is an inflammation of the bursa. And what is a bursa? It's basically the small sac where the synovial fluid is located. Signs and symptoms of bursitis that could include subacromial bursitis, perpatellar, retrocalcaneal bursitis, from pain to erythema, stiffness, stinging, burning sensation that surrounds the joint. You could see the actual fluid outside, creating a bursa. Etiologies are multifactorial. It could be trauma, it could be autoimmune disorder, it could be infection, or basically a trauma, or iatrogenic after surgery. Bursitis is very common when you have repetitive movement of the shoulder, the elbows, the knees. Patients with autoimmune disorders such as rheumatoid arthritis, lupus, gout, scleroderma, HIV patients could also have spontaneous bursitis. Or basically a traumatic injury. If you're kneeling down on your knees constantly, or you're, if you're housemaid and you're on your knees all the time, if you're a student and you constantly put your elbows on the table, you could have bursitis. Treatment is exactly the same. Rest of the joint, ice, elevation, NSAIDs, physical therapy. Only when the bursa is infected, or there's a high suspicion of infection, is only when you give antibiotic. Epicondylitis is basically an inflammation of the tendon where it attaches to the bone. There's lateral epicondylitis and medial epicondylitis. Lateral epicondylitis results from inflammation and micro tearing of fibers in the extensor tendons of the forearms. The symptoms include pain at the lateral epicondyle of the elbow, which can radiate into the forearm. Diagnosis is basically by examination or provocative testing, and the treatment is rest, NSAIDs, physical therapy. So you could get epicondylitis, for example, if you're using a manual screwdriver or hitting a backhand shot with a racket. In resistant trainees, you could get lateral epicondylitis. That's why it's called tennis elbows. Provocative testing, there is pain along the common extensor tendon when the fingers are extended against resistance and the elbow is held straight. Is basically a diagnosis, and you're going to see that in health assessment. The treatment again, rest, ice, NSAIDs, stretching. And basically medial epicondylitis is more or less the same thing. Now, rhabdomyolysis. Rhabdomyolysis is a condition where the skeletal muscle is damaged. You have breakdown of muscle cells that are released into the bloodstream, such as myoglobin, which is very harmful for the kidney. That could lead to kidney failure. Etiologies for rhabdomyolysis could come from crush injury to strenuous exercise, medications such as SSRIs and halothane anesthetics, drug abuse, cocaine, infectious process, patients that are in DKA, patients that have physical torture, car accidents, so all those trauma patients could get it. Patients that are status quo fall because of a stroke and they're confined into the same fixed position on the floor. Surgery, alcohol intoxication, statins. You're going to see in pharmacology that statins would give you high probability for rhabdomyolysis. Patients that are receiving antipsychotics, very related to neuroleptic Palignac syndrome, heavy metal poisoning, autoimmune disorders, again, such as dermatomyositis. The mechanisms for basically the pathophysiology of rhabdomyolysis is there is damage to the skeletal muscle. There is a crush of the myocytes that basically interferes with blood supply. When there is damage to the muscle tissue, that rapidly myoglobin fills inside the bloodstream. There is swelling at the level of the muscle due to destruction. There is deposition of calcium inside the sarcomera, producing continuous muscle contraction and depletion of ATP as the main carrier of the cell for energy. The neutrophils, you know that since they're the first cells that respond to inflammation, they activate, producing reactive oxygen species. The swelling inflamed muscle also could produce compartment syndrome that compromises further the blood supply. There is release of potassium, phosphate, and myoglobin, as previously stated, creatinine kinase, and uric acid that affects the DNA of the cell. There's also activation of the coagulation cascade that could precipitate DIC. These high potassium levels could disrupt the cardiac rhythm and produce fatal cardiac dysrhythmias. Rhabdomyolysis may cause renal failure. There is accumulation of myoglobin in the kidney tubules. Haptoglobin binds the myoglobin and basically is eliminated through the urine. That myoglobin in the urine concentrates the urine, producing destruction of the nephron as kidney reabsorbed or try to reabsorb the myoglobin. More water filtrates, and basically there are deposits of cast obstructing the normal flow. High levels of uric acid also are deposited. There is acute tubular necrosis, and the glomerular filtration rate falls to the point of renal failure. Diagnosis of rhabdomyolysis basically is due to high levels of myoglobin and the prior history that is reliable. LDH is elevated. The EKG you could have because of high elevation of potassium, presence of peak T waves, broadening of the QRS. The urinalysis, you could see the myoglobinuria. Treatment is basically to treat the underlying condition, try to be able to discern the cause, the main cause, treat the electrolyte imbalance, give plenty of fluid resuscitation to avoid renal failure. Osteogenesis imperfecta is basically an hereditary collagen disorder causing diffuse abnormal fragility of bone and sometimes accompanied by sensory neural hearing loss, blue sclera, dentinogenesis imperfecta, and joint hypermobility. The symptoms, hearing loss is present in 50 to 60%. There are basically 4 types. You have type 1, which is the mildest. Patients have blue sclera. They have deficiency in connective tissue that produces osteopenia and brittle bones. There's defective tooth formation and faulty hearing. In type 2, which is more severe and could be lethal, patients also have blue sclera. The skull is soft. When palpated, feels like a bag of bones. Trauma during delivery may cause intracranial hemorrhage and stillbirth in this type of patients. Type 3, of course, is more severe. They have, if they're able to survive, they have short stature, spinal curvature, and multiple recurrent fractures. They also have macrocephaly and triangular facies. Pectoral deformities is also present. Type 4 is intermediate in severity. If they're able to survive, they have basically the blue sclera, short stature, and the rest of the possible complications that the others have. Treatment basically is giving growth hormone and biphosphonates that improve the formation of osteoblasts. These are the stages of osteogenesis imperfecta. This is an X-ray and a baby with osteogenesis imperfecta. They have soft bones, very flexible, deformed. Now let's talk about achondroplasia. Basically is another type of cartilage and bone abnormality, which is also called dwarfism, DWARF, as in Frank, ISM, dwarfism. Leads to skeletal maldevelopment and short limb. Diagnosis is basically by physical examination, x-rays, and genetic testing. And treatment has to be surgical. The basic genetic defect has been identified in most of the patients with a mutation at the level of a protein. Epiphyseal plates close early in long bones. Individuals have short arms and legs, but they have normal spine and skull. The other organs develop normally, and they do live a normal lifespan. Diagnosis again by x-ray. You do a whole x-ray of the neonate if they're not a stillborn. You're able to see that they have early closure of the epiphyseal plate. You could also do laboratory testing of calcium, phosphorus, magnesium. Treatment again is most likely surgery. This is a normal child, and this is a child with achondroplasia, dwarfism. Osteoporosis. Osteoporosis is a progressive metabolic bone disease that decreases bone density. The bone density is no more than bone mass per unit volume. There is deterioration of bone structure. There is skeletal weakness that leads to fracture with minor or inapparent trauma. Diagnosis is by dual energy X-ray absorptiometry, which is DEXA scan, or basically by seeing the fracture in the X-rays and the porous bone present. The pathophysiology of osteoporosis: bone is continually being formed and reabsorbed, as previously explained, by the balance of osteoblast and osteoclast. Normally, bone formation and resorption are closely balanced. Osteoblasts, which are the cells that make the organic matrix of bone and then mineralize bone, and osteoclasts, the cells that reabsorb the bone, are regulated by parathyroid hormone, calcitonin, estrogen, vitamin D, and certain cytokines already mentioned, including prostaglandin and interleukin-6. The peak bone mass in men and women occurs by their mid-20s. Black reach higher bone mass than whites and Asians, whereas Hispanic population have intermediate values. Osteoporotic bone tends to occur or begin with menopause. Bone loss accelerates in women to about like 3 to 5% for about 5 to 7 years, and then the rate of loss decelerates. Osteoporotic bone loss affects cortical and trabecular bone. The cortical thickness and the number and size of trabecular disease results in increased porosity. The trabecular may be disrupted or entirely absent. Trabecular bone loss occurs more rapidly than cortical bone loss because trabecular bone is more porous and bone turnover is higher. However, loss of bone types contributes to skeletal fragility. Remember that osteoporosis is no more than an imbalance of osteoclast versus osteoblast. The endocrine system, remember, that maintains plasma, calcium, and phosphate necessary for osteogenesis. Elevated levels of cortisol increases the chances of osteoporosis formation. Is the most common metabolic bone disease in North America. Could be attributed by diet, hormone, or genetics. It could be idiopathic or secondary. Remember, idiopathic, you don't know the cause, and secondary could be due by either prednisone, cancer, patients that have COPD, patients that have chronic kidney disease, patients that are on glucocorticoids, anticonvulsants, progesterone, thyroid replacement therapy, alcohol, patients that have endocrine diseases such as diabetes, hyperthyroidism, patients that have immobilization, liver diseases, etc. Okay, and primary osteoporosis is basically unknown, or patients that are postmenopause. There's gonadal insufficiency, which is an important factor for both men and women. Other contributing factors of primary osteoporosis include decreased calcium intake, even though there is a hypothesis that it must not affect. Low vitamin D levels, patients that have any type of mechanism of stress to the articulation, any patients that have any major infection. The risk factors, ethnicity, as we already explained, tobacco abuse, alcohol, family history, signs and symptoms. Basically, the patient with osteoporosis is asymptomatic unless they have a pathological fracture, or when it's advanced, they have chronic back pain, they have compression fractures of the vertebra, spinal, discomfort, etc. Diagnosis. This is an example, pictures of compact and spongy bones, and when the patients have osteoporosis. It's basically more porous bone, poorly mineralized bone. And we're going to be talking about densitometry now. It's basically DEXA scan that you have a T-score to be interpreted. You have T-scores and Z-score. The T-scores correspond to the number of standard deviation that the patient's bone density differ from the peak bone mass of a healthy young person of the same sex and ethnicity. The WHO classification, the World Health Organization classification, establishes a cutoff value of T-score that defines, and you need to know this for your exam, osteopenia and osteoporosis. Okay, so a T-score less than minus 1.0 and greater than minus 2.5 defines osteopenia, and a T-score less or equal than minus 2.5 suggests osteoporosis. Then you have a Z-score that corresponds to the number of standard deviations that the patient's bone mineral density differs from that of a person of the same age and sex, and should be used for children, premenopause women, or men less than 50 years old. If the Z-score is less or equal than minus 2.0, the bone density is low for the patient's age, and secondary causes of bone loss should be considered. We already discussed the potential causes and the risk factors. We discussed that patients that have alterations with androgens and testosterone or progesterone, the sex steroids that also participate in the formation of bone, could have osteoporosis. It could also be caused by insulin-like growth factor, patients that have diabetes, patients that have lack of vitamin D, decreased magnesium, lack of exercise, family history, as already explained. Excessive phosphorus levels, sodas, junk foods, interferes with the calcium and phosphorus balance, increasing brittle bones. Often it's asymptomatic, as we explained, or producing back pain. Is mostly severe in the spine, the wrist, and the hips. Estrogen and androgens, as I said, may be factors in both sexes. There is rapid bone loss which is mediated by osteoclast, and slow bone loss mediated by osteoblast. These are the clinical manifestations if they exist. They have spontaneous fractures. They could have complications of restrictive lung disease because they want to be in bed, immobile. They are more prone to pulmonary embolism, pneumonias, and shock. There's no cure. You need to be able to slow the bone loss and promote bone deposition by improving osteoblasts, and this is done by bisphosphonates. Calcium and vitamin D supplements. You could provide calcitonin, and basically diagnosis is by DEXA scan and prevention. This is a patient that have, for example, hip trauma. An X-ray is either positive or negative. You assess osteoporosis for risk factor. If the risk factor is high and the energy level trauma is low, an MRI is indicated. If the energy level trauma is high, consider a CT scan and do the clinical reassessment. But basically, it has to be diagnosed by DEXA scan. X-ray only will give you pathological fractures being present. How do you prevent? By improving calcium and vitamin D and magnesium intake, weight-bearing exercises, avoid alcohol and tobacco abuse, avoid glucocorticoids if it's possible. If you're postmenopause, hormone replacement therapy, you could give parathyroid hormone, testosterone for male, and estrogen and progesterone for women. Osteomalacia has a pathogenic genesis very similar to rickets, which is going to be explained next. Is basically a disruption of normal bone remodeling. Because bones mature at different rates, both rickets and osteomalacia can be seen in the same person. Osteomalacia is characterized by an accumulation of excessive unmineralized osteoid on trabecular surface. Patients with osteomalacia are very fragile because they have softening of bones caused by vitamin D deficiency, which causes a defective of inadequate bone mineralization. In children, it's called rickets. It's the same exact disease, but it's not the same as osteoporosis. This is the normal anatomy, and this is the anatomy of the rickets. Remember that osteomalacia is basically a deficiency of vitamin D that lowers the absorption of calcium from the intestine. The bone formation progresses to osteoid formation. Diagnosis is established by evaluating the diet of the patient, vitamin D intake, phosphorus intake, radiographic evidence of skeletal demineralization and loss of dentine. There is also superosteocortical bone resorption, bone deformities, multiple fractures pathologically. The bone formation and calcification never occurs. There is pain, bone fractures, collapse of the vertebra, and bone malformations. Patients that have GI malabsorption, renal defects, and chronic kidney disease or liver disease are most commonly having this disorder. Rickets is exactly the same thing, but with pediatric population. It occurs in puberty in patients that have ignorance due to malnourishment. Remember, it's basically deficiency of vitamin D to form and participate in the metabolism of calcium. So therapy is basically vitamin D and calcium. They have soft spots. Fontanelles do not close properly. They have bony necklace. They have curved bones, bow legs. So this is the end of the first half of musculoskeletal presentation.